Welcome back, fellow mitochondriacs. I have a wonderful guest for us today. I have Dr. Tomas Duraj, who is with us, and he is a postdoc research fellow up at Boston College in the Seafried Lab. And I just want to say, first of all, welcome, Tomas, for
Thank
the
you. Thank you so
for
much, Casey, for
giving us your
having me.
time.
It's a
So,
pleasure.
do you want to introduce yourself, or how did you want to get
Sure.
started?
Yeah. I'm a postdoctoral research fellow at the Seafried Lab. I obtained my MD in Spain at the Rey Juan Carlos University. Then I sort of pivoted a little bit towards more a research, sort of physician scientist direction, and I did a PhD in translational medicine. Studying glioblastoma, which is one of the most aggressive brain tumors, and focusing on the metabolism of cancer stem cells related to that. And then I was offered a position as a research fellow here at the Seafried Lab because I was always a fan. I remember watching some of the scientific outreach that the Seafried was doing, and I enjoyed very much him spreading sort of the word and making people think about some of these topics more in depth. Thinking about also the theoretical aspects of why we are doing the things we are doing, the way we are doing them, and that got my eye. So it was a great honor to come here and join the lab. And I've been here for three years and counting. So it's very enjoyable.
I got you. And I mean, that sounds like a very interesting journey going from Spain to Boston in general, and then going from being a clinician to a researcher as well is also an interesting journey. And I guess, did you have interest in cancer like before medical school, during medical school? Did you like what led you even into the GBM area of research?
Well, I think these are two separate questions for me. So I was quite interested, partially for personal reasons, into the whole sort of ketogenic diet field, and more for like weight loss. And where you see me, I used to be quite a bigger guy when I was
Really?
younger, and these things were a learning experience for me to sort of understand a little bit of human physiology and metabolism. And then, after medical school, sort of slightly disappointed with the way standard clinical practice is performed for most people and most sort of medical fields. So I thought maybe research would be a sort of more trying to investigate the mechanisms and trying to learn about the disease rather than just sort of following very specific steps that other researchers already, have prepared for the clinician and said, this is the gold standard. We have to do this. You are sort of executing the research aspect. So I think there is a connection between both. I think this bridge needs to be bridged, to cover the gap between sort of the basic scientists that are in the lab and are trying to figure out the mechanisms, and maybe then they do like a small clinical trial. And I don't think that's enough. I think this needs to connect also with clinical practice a little bit more directly. So
100%.
I
I
yeah.
couldn't agree more with that. I, you know, when did you go through school? Just curious, what years?
That was 2010 to 2016, I believe.
Okay, cool. So that's around the same time as me. I graduated in 2014 from medical school, so I started in 2010. I I I don't know about you, but I had no inkling at all in what I was being taught that cancer was anything but a genetic disease. Was it the same? I'm guessing for your curriculum as well.
Yeah, absolutely. We went through the oncogenes and the tumor
Correct.
suppressors, and then sort of you switch to clinical oncology during the training, which is completely disconnected from any of that, any of the mechanisms. Maybe for some molecular analysis. Well, I think these things have advanced quite a lot in terms of like
Liquid
genetic
biopsies and
testing
yeah,
and
absolutely.
liquid biopsy and all these things, but not really informing the practice that much. You might see AGFR mutation, you might see, BRAF mutation, which can inform clinical practice, but it's not like you are really matching the patient to the molecular phenotype most of the time. So, uh, maybe this will change in the future. The problem is, as you know now, probably it's like the mutational heterogeneity is quite vast, and you cannot really match the
Yeah.
molecular measurements because most tumor cells start evolving into different directions in terms of
Correct.
mutations because they are downstream,
It's interesting.
epiphenomena. So
I watched a video with with Dr. Seyfried, as well as there's an oncologist. I think he's in like Alabama. I can't remember his name. And then it was Dr. Jason Fung, who's like a big fasting guy, nephrologist. And it was a great podcast. And it was Fung actually who got me onto this because I didn't realize this either. I didn't realize how vast it was. One tumor may have like 10,000 different mutations, like one tumor. So it is clearly biologic whack-a-mole that we're playing, with these monoclonal antibodies or whatever. And it's just, yeah, it's frustrating. Your PhD was in translational science, which is something that
mhm,
we lack clearly in clinical medicine to the basic sciences. And what I was saying was that again, it could be confirmation bias the way I'm searching the literature because it is so vast, but it just seems like every paper that I pull has at least a little blurb about Warburg effect, about glucose reliance, et cetera, et cetera.
mhm.
And I just can't understand. I get it. I'm an internal medicine doctor. Like, I get like an ER doc or like maybe a surgeon if they're not an oncology surgeon. Maybe we don't see this, in our realms. But oncology seems to be particularly disconnected, clinical oncology, from this biologic fact reality. Why is that, in your opinion? Because, I mean, just because of your background in translational science, I think that'd be a.
Yeah, I think there is like a quite a long research history of cancer metabolism. I'm not sure if most I think maybe endocrinologists are aware of some of these things, in terms of the hormonal regulation of whole body physiology. Uh, as for the oncologists, I think they know that there's higher glucose uptake in tumor cells. But maybe if they look back into the literature, they find that the targeted, with the mindset of, oh, we're going to find a targeted drug, and some of these have been successful in clinical trials. So I think they just shrug their shoulders and say, well, we cannot really do much about it. This is just high metabolic activity. They don't even call it like they don't think about the bioenergetics of the tumor cells versus the normal cells. They say, well, this is a high metabolic activity tissue that's growing out of control. We're gonna use a alkylating agent. We're gonna stop the DNA replication. The high metabolic activity will stop, and we will kill the tumor cells through the traditional sort of chemotherapy route, or try to find some targeted therapy or try to increase the immune recognition. Um, but yeah, I think more and more people are moving into cancer metabolism as a field, but sort of I don't know if it's an excess of caution or if it's just very conservative, but it's like very, very slowly moving towards like maybe we could do this, maybe the dietary interventions, but we don't really want to be too, intense for the patient. We don't want to like change their lifestyle at all. Maybe you have a obese patient with type 2 diabetes, and we don't really want to for them to lose any weight. So I think these are sort of I guess there is a disconnect between like a physiologist or like a researcher sitting in the lab studying these pathways, and then when you are actually in front of a patient and you're trying to apply these principles, uh, there is not a unified sort of codex where you could open a book or a guideline and say, okay, you have glioblastoma. We're gonna do these three things. We know that 50% of patients in a phase 3 clinical trials that did these three things have obtained benefit versus randomized, placebo blinded people that did not, which is impossible to do, of course,
Right.
for dietary intervention or fasting. I think people are quite aware if they have been fasting for 7 days. So
It'd be pretty tough to blind that one.
yeah, well, you never know, but people try. But I think, I think it's proof of principle needs to advance a little bit more just to give both people and oncologists the numbers. But I also think oncologists should be a little bit more open-minded. And I have great respect for the profession. I know these are very intensive training, but I think just the training is quite narrow for all of medicine. But
Yeah.
we have been especially critical for oncology just because I guess it depends on the diagnosis, but for some of the more advanced, either metastatic cancer or
Right.
glioblastoma, which is one of the reasons why we chose glioblastoma as a good model, not only for the metabolism. Often you hear, oh, GBM is highly glycolytic, therefore it lights up on the PET scan, therefore it's a good model to target glycolysis through a ketogenic diet or something like that. That's not really the reason. As you know, we feel most tumors share these characteristics, and they share nearly universal uh, metabolic phenotypes
Hmm.
or in terms of bioenergetics. But I think the reason is more because for me the rationale to be more flexible with the standard of care is much more strong for a glioblastoma or a metastatic advanced cancer rather than a stage 1 or 2 breast cancer or prostate cancer. I think these are, you should still do whatever is in your power to improve the odds of no recurrence and good outcome, long-term outcomes. But maybe you don't need to incorporate glycolysis inhibitors, glutaminolysis inhibitors. Some of these things maybe are not necessary. But for something like GBM, where the standard of care long-term outcomes at 10 years are like 0.8% of patients surviving.
Right.
And as you know, most of them are like, oh, if you're living with a GBM, you are most likely misdiagnosed. You might have, a grade 4, a grade 3 astrocytoma or something like that. And then I think that's, sort of circular logic. Therefore, everyone with a GBM is sort of like a death sentence, which I think is not the case. But the long-term outcomes with standard of care are very, very poor. So I think it should be sort of logical to be as flexible as possible.
Got it. I guess, I mean, obviously, everything you said, I think there's a lot to unpack there. And I think some of that I'd like to hold off on, like about something I've been thinking about in terms of like, depending on the spectrum of disease, like how aggressive you should be, even for ketogenic metabolic therapy. But I think that the answer that I got from you basically was, um, in terms of why oncology in particular is kind of the answer we have for all of medicine. The same reason you were disenchanted after your fourth year, is that there's just almost no emphasis, excuse me, on lifestyle interventions whatsoever for almost any pathology, right? But cancer is like a specific one that's even the worst, right? Because at least with diabetes or obesity, like we know that like you can do some exercise, you can maybe it's not as aggressive as a recommendation that we'd like to see to really like get that blood sugar down, get that weight down, but like at least it's there within cardiology, within endocrinology, within even gastroenterology is kind of waking up in some ways, with like elimination diets and stuff like that. But my point is that oncology is this other specialty, which is I'm an internist. So like these guys, they all went to internal medicine residency, right? They all go do a fellowship in hematology oncology afterwards, for another, I think, 3 years. So it's one of our specialties. It's just that specialty seems to be the most like aggressively hands up. There's nothing you can do, and the literature wouldn't support that, I don't think. I mean, even if you were just looking at glucose levels of people with diabetes, the higher your A1C, the higher your glucose level, generally, the poorer your prognosis is.
Yeah.
So, I mean, it's there, so.
I think maybe that's a little bit of paternalism sort of sneaking in from the old days. I don't envy, I'm not an oncologist, so I don't envy their job because I think they feel they must sort of protect the patient in quotations. They want to offer what has the highest level of evidence, which is logical. And I wouldn't, well, often we are quite critical of oncology as a field. And I wouldn't blame neither the patients nor the professionals giving them the best care that they feel they can. I think there's also like limitations in resources. This is one of the things that I think it's different from when we are thinking about ketogenic metabolic therapy because we are trying to sort of, it's a difference in mindset because when a patient goes to the oncologist, and let's just stick to oncology, I feel from the patient's perspective, he thinks the physician will do everything that's in his power and above and beyond the best clinical trials, the best research modalities. He will sit down and he will spend 5 hours investigating that's exactly for the specific tumor what is the best treatment for the possible best outcomes, trying to
Right.
navigate the uncertainty and the risk benefit ratio for 5,000 different interventions that they could do. But of course, that's not what the physician is doing. The physician is sort of following standard of care. You are one more patient that they might need to see. Maybe they have 50 others that have the same disease, and they just go sort of through the standard of care guidelines. So I think there's this disconnect maybe, and then the patient needs to know this and sort of take things into their own hands, at least for now. Maybe in the future, many of these things will slowly be integrated into standard of care. We think metabolic oncology will definitely be an aspect of standard of care, but they always try to sort of the field always tries to, I don't know if it's to make it less invasive as possible, but they try to like cheat sort of it a little bit. Like many of the clinical trials in either ketogenic diet or like amino acid restriction or many of these things, insulin suppressive diets, they are like, we're going to send you a package of food that you will eat for 3 days while you are taking a PI3 kinase inhibitor. And we're going to test this in a clinical trial. I think, I wish we would be like mice where the metabolism is so fast. Then, you wake up one day, you are, high carbohydrate diet, you wake up the next day, you are suddenly in complete nutritional ketosis.
Right.
Everything has switched overnight. But these things take, weeks and months to the whole body physiology and the expression of transporters and proteins and different pathways slowly adapt over time. So I think it's just not possible. The
Right.
way the field would like to do it as a sort of little package that they
Right.
send to your house, that you don't have to think about it. You just eat this and you do that. This is just not possible. I think that there
Right.
is a learning experience from the patient that they need to do.
Right. Yeah, that is not going to work. I thought you were talking about with BRAF and ketogenic diets. I thought that, there's kind of going into that. There's papers that I personally believe are at minimum muddying the waters with ketogenic diets and certain mutations, and have pretty provocative and scary titles. And of course, people send them to me and they're freak out. And one of the ones that I was thinking about was, I think it was a BRAF mutation medicine. I think it was like a
In
pancreatic
melanoma.
cancer patient or paper. But if you actually dug through the paper, like you could pick it apart in some ways, like, but the title was scary. And I was actually like, holy crap, maybe this is something here, for a while until I read it. And I'm like, okay, I actually did a video about it. But do you think there's like an intentional muddying of the waters, or do you think it's just like they don't have the right mindset, or like what is it?
Well, I think if you come into the research field, you will see quite quickly what's going on, and this is just sort of how research works, where uh, the research groups are incentivized to find novel observations, even though there might be none. So sometimes, many times there is like a phenomenal observation where you have mice, you put them on a ketogenic diet, let's say, and then the tumor grows, a little bit faster. And now you say, okay, let's figure out what happened here, and then you measure a bunch of metabolomics, a bunch of pathways, and of course there might be some rewiring and some adaptations. But maybe what you fail to measure is, first of all, what is the glucose, what are the ketones? Maybe the glucose is still elevated, the insulin might be still elevated, or they are eating ad libitum, which for mice, the ketogenic diet should be at least slightly calories restricted. So there is like methodological issues that they are brushed off towards the more gene-centric sort of perspective. And you can find many of these sort of observations that do not fit because the execution of the methodology it just takes a lot of work to in the preclinical models to really learn. Talking about the BRAF, I know there was a couple of papers where they suggested that in melanoma might be like using ketone bodies when it has the BRAF mutation, and then the group of Barbara Koffler, she sort of repeated the same experimental design. She just did across different animal models. She just varied the diet a little bit, a little bit more careful with the feeding of the animals. And she saw an anti-tumoral effect across all models of melanoma, including that one. And it's like exactly the same thing. It's the same cell line in the same mice, just different implementation of the dietary intervention. So I think, these things matter. We are not trying to discount them. We need to learn more to explain. But it's a little bit sort of tiring to, we always get, these papers like, oh, look, it didn't work here. And then we could spend, 3 years trying to replicate. We are trying to work now, for example, on metastasis. There's this 41 model of breast cancer where some authors observed higher metastasis in a ketogenic diet group. And, we are repeating this preliminary. We can see just if you adjust a couple of things in the dietary sort of implementation, the metastasis can be greatly reduced or not, not even there. And this is like a 90% Crisco diet, so that's also sort of not the most representative of what most people are doing in the clinic.
Got
So I
it.
think this is gonna be like an endless discussion on the scientific front. That's why maybe they always try to push us to to have more clinical observations, which to my knowledge, as I always say, I've never seen any paper so far that would see like a hyperprogression or like an acceleration of tumor growth with a ketogenic diet, regardless of how it's implemented. Usually in most clinical trials, it's ad libitum, is even hypercaloric, which in the mice it's not a good idea. But I think the human metabolism is a little bit different. So you can have at least eucaloric. I wouldn't do a hypercaloric diet on purpose, even if it's ketogenic.
Right.
But I think you can have eucaloric diets that are still either neutral or beneficial, and they do not accelerate tumor growth.
Got it. Um, one of the things that I was a little bit surprised about was that when I talked to Dr. Seyfried, um, I asked him, like, to what degree does it need to be hypocaloric, right? Like I wasn't clear, is it 250 calories under maintenance? Is it 1 calorie under maintenance? Is it 1,000 calories under maintenance? And he gave me an example of how calorie restriction worked in mice. Basically he said that like a 50% or 40% calorie restriction in mice was equivalent for a human because of the metabolism differences of like a 21-day fast. So I was like, well, how can being under maintenance 250 calories of a person make a difference if that's the case, or does it make a difference?
Well, that's a good question. I think the issue with the translation between a rodent, a dog, a primate, these if you only look at the the metabolomics, if you just look at glucose and ketones level, for example, or how much does a 40% calorie restriction decrease insulin signaling and glycolysis, glucoglycemia from baseline to whatever the new level is. And in mice, it also increases ketone body production, ketogenesis. I think you cannot really translate that. Those observations you might see in a person that has been fasting for 7 days, 14 days, 21 days. But I think on the tissue level, I think there is other things going on that maybe we cannot directly capture with that comparison. Because a 40% calorie restriction or 30% in a human that is eating sugar, only sugar, I think you will not see those adaptations because the metabolism is slower. There is glycogen in the liver, and you have to deplete that. There's also glycogen stored in the muscles. So all these things, it's not the same sort of one-to-one comparison with calorie restriction. I would say.
I got you. So I guess what I'm hearing you say is that you do believe it needs to be a caloric, okay, so the amount of calories you need to take in, basically based off your basal metabolic rate, or slightly below, or much further below. Like I know everybody's an N equals one. Obviously, if you're 90-pound bones, patient, cachexia versus, obese, diabetic, there's going to be a difference in the amount of calories that person can tolerate. But is there a general recommendation of how far below maintenance that would be useful?
Well, I think this is context dependent. Maybe here we could talk about the glucose ketone index and sort of
Okay.
how it's structured. So of course the glucose ketone index is on a continuum, I would say, but I would say ketogenesis is sort of like a semi-binary state. Um, you are either your liver and your kidney are either making ketones or they are not, and sort of they are trying to sense these organs sort of as a master regulator of metabolism. They are trying to sense the energetic levels in the body. So when carbohydrates are low, or when you are fasting, the liver will produce ketone bodies, beta-hydroxybutyrate, acetoacetate, acetone, as a sort of marker of a whole body metabolic shift towards fatty acid oxidation, and fat-derived fuels, including ketone bodies and other oxidative metabolites. So in the glucose ketone index, of course, you have the glucose levels, the glycemia in millimolar, and the ketonemia, ketone levels in the blood in millimolar. And I think it depends on the person. Like a slightly overweight, a person maybe that has a little bit more adipose reserves, a caloric restricted diet for that person is actually eucaloric. If you're 100 kilograms and your ideal weight, and let's forget about lean body mass and all these things, because that also factors in the equation, is 80 kilograms. Maybe a 10, 15 calorie restriction for that person is actually eucaloric, because when they get to 80 kilograms, they will just maintain their weight.
Correct.
So they were over that level. So I think with the GKI, you're sort of trying to capture these metabolic shifts. You are trying to. We cannot measure many of these things at the tissue level. We would like to measure, insulin signaling and PI3 kinase activity and glycolytic flags and glutamine flags, mTOR, AMPK, autophagy, all these things. We would like to measure them in the tumor or in the tissues, the normal tissues, but you would have to do a biopsy for that and send it to a research lab. So we are trying to sort of estimate those things with sort of a chronic number of the glucose ketone index. So if calorie restriction is necessary, I think will depend on the person, because a person that is already like a BMI of maybe 18 or under, they should be probably eucaloric, because they are already calorie restricted.
Correct.
as they stand. Whereas a person that is 25 BMI, 20 to 25, I think they can sort of play around with it. There can be periods of slight calorie restriction, maybe 10, 20%, during maybe different therapeutic interventions to try to optimize the GKI levels, and then maybe they need to recover a little bit of lean body mass and fat mass, so they can do a slightly eucaloric period, or slightly hypercaloric, but hypercaloric relative to the calorie restriction that they had before, so they sort of recover back a little bit of fat tissue reserves.
One of the things that I was interested in looking at, because it's obviously no clinician really wants a patient to lose a lot of weight during treatment, right? Or any treatment. I mean, unless they really got a lot to weight to lose, right? But I think if we're talking about that person who's got the lower end of the BMI, 22, 21, 20, God forbid, less than, 18, like you were mentioning. Most people think about a ketogenic diet as being a weight loss diet. I mean, you said yourself, you were interested in ketogenic diets, talking about like weight loss, diabetes, metabolic syndromes, et cetera. But when I was going through the literature, looking at cachexia, cancer-related cachexia in particular, it seems that I know you guys don't like to use the word Warburg, but that's in my brain. But the cytosolic substrate level phosphorylation, particularly the lactate, seems to be at play here. It reprograms fat cells to like modulate like your metabolic rate, and then the lactate going back to the liver through the Cori cycle to the liver. That's a energy basically dependent process. And so basically, being on a ketogenic diet for cancer, it seems, could be a way to maintain weight, even though we think of it in our brain as being a weight loss diet, which I thought was interesting.
Yeah, I wouldn't say it's a weight loss diet. I would say there are no weight loss diet at all. It's a balance of the endocrine system, the hormonal system, and yes, calorie intake on paper, of course, plays a role, and the energy needs of the person. I think ketogenic diet, Dr. Seyfried got interested in that after working on, as he always says, on calorie restriction for the mice. In these brain tumors. They observe very, very interesting antitumoral effects, very powerful antitumoral effects. But when they tried to bring it into sort of clinical application, they were met with resistance. And this is logical, because you cannot have a child with a pediatric brain tumor or a older adult that is, as we said, maybe a BMI of 18 or 20, put them on a 40% calorie restriction while they're doing chemotherapy.
Right.
So the shift to the ketogenic diet was because it's one of the few diets, as you know, that can dietary states or metabolic states that can mimic most of the effects of fasting without requiring such striking calorie restriction. So you could have maybe 10, 5% calorie restriction with a ketogenic diet, and you can reap many of the benefits on a molecular level and endocrine sort of signaling level, growth factors, all these things from fasting, fasting mimicking diet to 100% water only fasting. So that's sort of the shift, and we are aware that patients cannot be fasting forever. At some point, some energy must enter the system,
Right.
some macronutrients must enter the system. So it's sort of the choice what macronutrients are these going to be? Is it going to be a raw fruit diet, or is it going to be sort of a low carbohydrate, animal ketogenic animal products, or it doesn't have to be animal products. It can be
Right.
also different supplementation of protein and fats, and which one is sort of more evolutionarily conserved, which one fits more the long evolutionary history of let's say mammals or our lineage, the Homo sapien lineage on the
Right.
planet. And I think ketogenic diet is more fits that more than other diets.
I agree. And, I've heard you say this. I watched some other podcasts that you were on, one of which is a guy that I also did, who's in the UK, the
Ben,
Degrees of Health podcast. I saw you on that one, the two-part one you did. It was excellent. And, you mentioned this kind of very quickly. It wasn't elaborated on, but there are people out there, they just is what it is. There are people out there who don't know better and put people on treatments, alternative treatments that could potentially harm them. And there are people who try to take advantage. There are people out there who just want to try to take advantage of people being in a delicate state, and I think that's true. I mean, I've heard, look, I'm willing to be wrong about anything, because I don't know everything. But there are, diets that are very high in fruit and fruit juices, for example, that they have their reasoning why they believe that it could potentially help, but biologically it doesn't seem like it would be safe. And so I think that's an important point, that it is the most. I think this is a question I had on here, that I had for you, but does and ketogenic metabolic therapy seems, at least from my non-researcher perspective, that it makes the most sense biologically as a dietary intervention. Is that fair to say?
yeah, I think so. I mean, what you mentioned about different alternative sort of dietary tools that may be used, I think we have to be careful. Also, I think this usually comes from a well-intentioned place, with complete disregard to like physiology and like human evolution, but it does come from a good place. But many of some of the mechanisms can be shared. Like we are not opposed to a plant-based diet. We don't want to get into the diet wars.
I know.
Um, and on a some certain types of plant-based diet, when they are well designed, I think they can work even in a ketogenic state. It's just much more difficult to do, but it is possible. Um, Although I would say, if you're dealing with advanced cancer, maybe some of the ethical dilemmas can take, a little bit of a second consideration compared to a life-threatening tumor. Uh, but at the same time, if some of these diets, even if they are not well designed, they might share all the calorie restriction sort of effects, because many times when people switch from standard American diet to whatever other diet, as you know, um, they will reap benefits through calorie restriction. If you lower fat completely, if you are doing a diet that is 5-10% fat, very low protein, only carbohydrates, you are still sort of shifting towards some of the effects of calorie restriction. Uh, Although we would say, we have to be careful about the lean body mass loss and the micronutrient deficiency.
Right.
And I think this can be also a stressor for the tumors if it's short term. If you go from complete, strict ketogenic diet to uh, low carbohydrate, low fat, low protein diet, which is basically like as close as fasting as you can get,
Yeah.
you will, some of the mTOR signaling will be lower because you are not bringing amino acids into the
Right.
body, and many of the pathways shared with calorie restriction will also be activated. So I think as short-term interventions, I'm not opposed to these things, but something long-term that you are trying to implement as a metabolic stressor to the tumor cells, to sensitize them to other interventions, and something that actually keeps the body healthy long-term. It's not impossible to do with other tools,
Right.
but I just think you need to be much more smart about it.
Yeah.
Therefore, I think for most people, sort of Paleolithic ketogenic diet or something like that incorporates how we evolved makes more sense. It's more easy to implement without thinking about all these secondary factors.
Got it. Yeah, I think for me, the main secondary considerations for something like, that is the basically the flavonoids and the polyphenols that are there. We're talking aside from macronutrients, micronutrients. And I asked Dr. Seyfried this, and I think it was just me not asking the question correctly. So I'm gonna be very deliberate the way I ask it to you, and just I want your opinion. Basically, there is literature, meta-analyses that show that the higher the amount of flavonoids a person takes in, or polyphenols, there's two different studies that I saw, the lower the mortality is with cancer. I found that to be a paradox. Once I went through the USDA databases and found that the majority of the polyphenols for most people are in some vegetables. There's no question, green leafy vegetables and some of the, some starchy vegetables have some polyphenols, but the majority were in either spices or fruits, and particularly berries. And I found that to be perplexing to me because obviously a berry is generally mostly carbohydrate and fiber with the polyphenols. And the polyphenol content or the flavonoid content can vary widely. A strawberry that's conventionally grown may have 20 milligrams per 100 grams of that fruit, whereas a wild blackberry may have 600 milligrams for 100 grams of that fruit. And so my point by telling you this is that I at least on this channel, I've spent a lot of time studying the effects of non-drug interventions that are a lot of times polyphenols or like quercetins, the EGCGs. These are all flavonoids, right? So I'm like, okay, it makes sense to me that those things would have an anti-cancer effect, but it doesn't make sense to me that someone who would maybe be on a higher glucose diet, would have a better chance of surviving longer because of that. So I don't know if the flavonoids are overpowering the glucose that's being taken in by that type of a diet or what I'm missing. But I don't know if that seems like a paradox to you or not, but it does to me.
Yeah, not doesn't really seem to as a paradox. I mean, I would have to look at those specific data sets. I imagine those are epidemiological data sets, which, as you know, are not the most reliable. But in association, I would say, maybe this is simply an effect of standard of care, standard treatments that are buffered a little bit better by all these, let's say a healthy diet, a polyphenol rich, flavonoid rich
Right.
diet that may be supporting the normal cells of the body, the normal cell ecology a little bit better. And then the standard of care is doing its effect. And, across all tumors where in some tumors, the standard of care can be very effective, you are seeing maybe a slight nudge of the survival rates. I think this is a little bit different from talking about cancer metabolism specifically. I think when we focus on a high grade metastatic tumor or on a glioblastoma, and we are trying to figure out from a purely metabolic perspective what would be the optimal whole body physiology metabolic state that would put pressure on the tumor, and what would be the interventions, the metabolic inhibitors or dietary interventions that could put even more pressure, synergize with standard of care. Those are like unrelated. Like, well, no, it's not completely unrelated, but the the handful of berries that you might have in the diet, I do not think it's more to support the normal cells. I do not think it's like all those flavonoids are like directly going to the tumor cells and like signaling apoptosis in a tumor cell. Although on this is one of the problems with many of these things, including the supplements. It's like they might be compounding, so we don't know if each of them have a 0.5% effect or
Right.
0.1% effect, but you are taking 20 of them, how they are interacting. Is it, helping, not helping? Is it putting more pressure on the tumor. I think in principle it should. It's very hard to find reasons, biological reasons why it wouldn't.
Right.
But I think the dietary sort of status of the long-term diet that a person might be doing within like eating a normal standard American diet and just throwing in vegetables or some of these things, I don't think that has like direct effect on the tumor. I think that's more mediated by the normal cells.
Got it. Okay. Going back to macros and GKI. This concludes part one. It looks like it's going to be of three because we talked for so long. We talked for more than 2 hours. I wanted to make it in somewhat digestible pieces of information for you. I've kind of broken into where the natural stopping points are, talking about diet, then repurposed drugs, then oxidative therapies and beyond. So I had a great time talking to Tomas. I hope this is the first of many times I get the chance to talk to him and see what is the cutting edge up at the C-Free Lab. If you like videos like this, please like, share, and subscribe. And until next time.